in terms of follow-up, how do you surveil these patients post-op?
Yeah. So again, I think this is a great question. No one really knows because there's really no long-term, super long-term data like there is in radical prostatectomy and radiation. But again, based on some consensus statements, I think how I kind of view my practice. There was a Kyoto consensus back in 2019 that kind of breaks this down, and I tend to use that in my practice. And I think the way I frame it is, after HIFU, I tend to get a PSA every 3 months just to, kind of see what that levels do. We've looked at our data here, and I think about a majority of our patients have over 50% decrease in their PSA after the initial ablation. So that's something that I would like to see in my patients. It doesn't have to be seen, but it's something that I think makes me a little bit more comforted. And then I tend to get not tend, I almost always get an MRI and a protocol biopsy at 1 year. And that's what I also, part of that is some patients come and say, well, do I really need to do another biopsy? But I frame that discussion really at the time when I offer focal therapy. I say, if you're going to do this, we need to make sure you get PSAs every 3 months and you're going to get an MRI and a biopsy again at 1 year because I really want to make sure that I understand if this therapy even worked or didn't work. And so my follow-up really is 3 months, PSAs, biopsy, MRI at 1 year. I rebiopsy them again at 3 years as well, including an MRI. And then the PSA is probably every 6 months and somewhere in between in that interim period.
Cool. And in terms of your you've been monitoring your outcomes and is it consistent with the data in terms of both function and oncologic outcomes?
Yeah, so let's talk functional first.
Yeah.
I think as I mentioned, functional outcomes. If we talk about erectile dysfunction, and then if we talk about erectile dysfunction and incontinence, erectile dysfunction is always a moving target. Really, never, it's never really clear in terms of, it's just always a moving target, right? So some patients do worse, and some patients tend to do better, but that really doesn't make any sense. But when you look at the literature, it tends to be around 5 to 10% may have erectile dysfunction associated with HIFU. I think when we look at our data, when we do we do HIFU for everyone, we put them on a prospective data collection protocol. So everyone's on a protocol for us, and we collect their data prospectively. It's somewhere around 5%. It tends to have erectile dysfunction. Again, that's very variable, right? So if you have a disease that's kind of in the middle of the prostate, well away from the capsule, I think for the most part, you're probably not going to get close to ablation of that nerve, right?
Right.
But that said, if you have kind of more lateral disease, you're going to want to probably go a little bit outside the capsule to be able to make sure you get a good margin there. Those patients may suffer from ED a little bit more than the others. So again, it's hard to really, whenever you look at these
Right.
things, comparing apples to oranges, and never
Right.
really in the same context. So it's hard to really compare the two. For incontinence, we've had, I think again, the literature is around 5%. I'd say for us, it's even less. So and a lot of this has to do with, if you think apical disease is easy to treat or not. And we tend to treat it if it's MRI visible, but if it's MRI invisible disease, we tend not to really treat the apex. But that's something that, again, every practice can do very differently. So overall, compared to radical prostatectomy radiation, I mean, the functional outcomes they compare in no way. They're just so much better than any type of radical therapy. Then
Absolutely.
when it comes to oncologic efficacy, I think the literature kind of looks at somewhere between that 15 to 20% of finding clinically significant cancer in the field of ablation at 1 year. And I think if we look at what our outcomes are, it's pretty similar to that. I'd say it's somewhere around 10 to 15% when we looked at our last outcomes. But the thing that we are doing, and it's kind of being adopted more and more in kind of the, at least in the HIFU context, is something called a second pass. So we ablate the area of concern, whether that be a hemiprostate or just a lesion of concern, and then we're actually going through and we're ablating it again. Similar to cryotherapy, right? Where you're doing typically most people do a 2 freeze-thaw cycle. So we're doing kind of the same thing. And we've actually been able to see that our recurrence rates have dropped really less than about probably 5 to 6%. And if you look at the data that actually kind of prompted all of this, is from Martini Clinic. I think they had an AUA poster back in 2022 or 2023 that really showed that their recurrence rates dropped to around 7% with the use of second pass here. So that's something we're doing kind of relatively newer, and we're seeing much more improvement in our oncologic efficacy at 1 year. So that's pretty exciting for us.